Let's talk terminal secretions for just a moment. I'm Chelsea, the palliative PA, and I like teaching about palliative care and end-of-life care. And if you want to learn about these things, hit that follow button and come along for the ride. So terminal secretions, also sometimes referred to as the death rattle, can be very scary for the family at the bedside. And there's a few things that we can do that I wanted to point out today and a few reasons why to use one over the other. So a couple of things to keep in mind. One is that absolutely we can use some as needed suctioning in the mouth. We don't usually do deep suctioning at the very end of life because that can be uncomfortable. Oral suctioning or just kind of scooping things out, totally fine. The other thing is position. So sometimes propping the head of the bed up 30 degrees can be helpful. Sometimes actually laying someone on their side can also be helpful. So just some positional things to keep in mind. The 3 medications that we usually use in my practice, one is atropine drops. So these are typically an eye drop, but actually can be put in the mouth in a couple drops every couple hours, or more often if they're really working well, just to help dry out the secretions in the mouth. The other is Robenal or glycopyrrolate in IV or oral forms. So it's either a pill or an IV, and this is generally a drying agent, so just dries out those secretions. The third one is a scopolamine patch. So that little seasickness patch that I mentioned the other day, it can be used for these terminal secretions. So why to use one over the other? So the easiest one that is most often used is the atropine drops, because if someone is unable to swallow or they're not waking up well enough to take a pill or do anything like that, those atropine drops can just be put in the mouth. They absorb very quickly, they dry very quickly. The scopolamine patch obviously is super easy too, because it just gets put on the back of the ear, but it takes 6 to 8 hours to kick in or longer. So it's something that if somebody really has a lot of secretions now, they can't wait for that patch to kick in. So we want to use something a little bit faster acting, and that's a lot of times where those atropine drops come into place. Now, IV Robenal is also super fast acting, and oral Robenal is a great option if someone can still swallow. If they can't swallow, they can't use it. But something to keep in mind, so both atropine and scopolamine cross the blood-brain barrier. Why is that important? That means that they can have actually neurologic side effects. So specifically, scopolamine can cause people to be more sedated and more confused. So if someone is awake, having good quality time with their loved ones at the end of life, I don't actually like using a scopolamine patch unless they have really severe secretions, because we could actually sedate them and kind of ruin some of that quality time that they have at the very end of their life. Now, if somebody is already unconscious toward the end of life and has a lot of secretions, I will almost always have them put on a scopolamine patch just to help dry out over time. The other thing is the Robenal does not cross the blood-brain barrier. So if someone is having good quality time at the end of life and the IV option is available, then that's a great option because it's not going to cause sedation or confusion. Same thing goes with the atropine drops. They do technically cross that blood-brain barrier, and same thing can cause a little bit of confusion, but they are super easy to use, and that's why they're a lot of times utilized first. Hope this is helpful. Let me know if you guys have follow-up questions.